Good evening, all. Today, we will be discussing about the most commonly used gadget across all anesthetic societies and all anesthetists, which is the oxygen delivery devices, maybe our anesthesia circuits or nasal prongs or simple face masks to the ventilators which we use in the ICUs. These oxygen delivery systems are imperative to know as to how the oxygen is delivered, how much the oxygen is delivered, which patient requires higher fraction of inspired oxygen and which patient will require lower inspired fraction of oxygen, and what are all the classification of these devices. So it is imperative that we understand the oxygen delivery systems as a whole. So why are we even talking about this is to treat the hypoxemia, we need oxygen because oxygen basically is life. So treatment of hypoxemia, which can occur either due to hypoventilation or due to V by Q mismatch, or it can happen either at atexesis or whenever the patient is induced. So V by Q mismatch can happen. And to improve the oxygen supply to tissues and as a treatment for carbon monoxide poisoning or when there is a low atmospheric pressure for survival, then for mountaineering and all that, for survival itself, they will need oxygen. So these oxygen therapies are given to patients who are actually going under anesthesia because basically the patient is not going to breathe. You are going to supply them with oxygen. So somewhere around 0.5 percentage or 0.6 percentage of FiO2 is tolerate, like 50 to 60% is tolerable. And WHO sometimes ago said that 80% should be the tolerable FiO2 which should be used. So basically in ICU setting, depending upon how the patient's ventilatory demand is, how the oxygen demand is, the patient may require either face mask support or invasive ventilatory support. So this oxygen can also be used as alone therapy or in combination therapy, as in case of Entanox, which is actually 50% oxygen and 50% nitrous oxide, or in case of Heliox, wherein it is 29%, 21% of oxygen and remaining is helium. So these can also be used as a combination therapy. So coming to topic proper, which is an oxygen delivery, it can either be normobaric, as it happens when the oxygen is supplied at a atmospheric pressure, and hyperbaric oxygen therapy when oxygen is usually supplied at higher atmospheric pressures than the normal atmosphere. So these oxygen delivery systems can be divided into normobaric and hyperbaric. And in normobaric, depending upon the extent to which the patient relies upon these devices to correct the oxygen deficiency, these can be classified again into low dependency, medium dependency, and high dependency. In low dependency, depending upon the FiO2 which is delivered to the patient, it can again be classified into variable performance and fixed performance. Again, in low dependency, this can again be classified into the devices based on their capacity. No capacity, medium capacity, high capacity, and very high capacity. So that's how it goes. So depending upon the dependency, to extent to which the patient depends upon the oxygen delivery system to correct their hypoxemia, it is first classified as low dependency system. So when only supplemental oxygen alone is enough to correct the hypoxemia, as in the patient is breathing spontaneously in a postoperative ward when the patient is having hypoxemia, we do not require in most of the patients, like you do not need a CPAP to provide adequate oxygenation. Their saturation will be somewhere around 90% because they are asleep, or when there is a residual neuromuscular blockade, even after you have reversed properly. At that point of time, you can use a nasal prongs or standard face mask so that your oxygen requirements will be met. So that is a low dependency. Suppose if your patient is having a community acquired pneumonia and is in respiratory distress, and at that point of time, you need a minimal amount of CPAP to supplement and to overcome the respiratory system's resistance. In that case, when you need a CPAP as an additional support. So when you need a high flow nasal oxygen cannula, which can actually provide you a continuous positive peak expiratory pressure, at that point of time, the patient will have a medium dependency. So whenever the patient is extremely tachypneic and the patient's minute ventilation is going high, sky high, and the patient's requirements are very high, even using a medium dependency, at that point of time, when your Medium dependency also is not working. You need to resort to a ventilation which should support continuously to the patient. May it be a non-invasive intermittent positive pressure ventilation or full intubate mechanical ventilation, intubate and mechanically ventilate. So that becomes a high dependency. So for this becomes imperative topic of ICU. So I basically cover these two, the medium dependency and low dependency oxygen supplies. So in the low dependency, so it is again classified into low flow systems and high flow systems. In the low flow systems, you have nasal cannula, simple mask, and reservoir mask. Again, the reservoir mask can be classified into partial rebreather and non-rebreather. In the high flow system, we actually have Venturi mask and HFNC blenders. So these two are high flow systems. As of now, we are talking only about low dependency unit, and depending upon where how the flows are used, the low flow device versus the high flow device. In low flow device, you will not have any constant FiO2 which is delivered to the patient. Depending upon the patient's respiratory rate, tidal volume, and minute ventilation and peak inspiratory flow rate, your FiO2 will be keeping on varying. Whereas in high flow oxygen devices, the FiO2 which is delivered is constant. This low flow devices uses only up to 15 liters of oxygen, whereas high flow devices such as HFNC can use up to 60 liters per minute of oxygen. And this actually delivers a mixture of oxygen and air. And usually the FiO2 will vary with tidal volume. Suppose if the patient is breathing, having a lesser minute ventilation, then the FiO2 will tend to be higher. Suppose if the patient is having more minute ventilation, then your FiO2 will be lesser. So this HFNC or your Venturi will provide predictable supplies of FiO2. And low aerosol generation in low flow devices and high aerosol generation in high flow devices. So these low flow devices can be used to mild to moderate hypoxemia patients. HFNC can also still be used in patients with severely hypoxemic patients also, provided that you monitor the patient clinically as well as using the ROX index. So as of now, we have seen high flow versus low flow. This is high flow versus low flow device. So as we have seen here, the low dependency will be of two types. One is low flow, another is high flow. In the low flow, as of now, we are going to see these are low dependency device. These low flows are low dependency device. So this can either be classified into variable performance and fixed performance device, depending upon the FiO2 which they will deliver. So what are the factors which determines how much FiO2 is being delivered to the patient is classified into equipment factors, patient factors, and additional factors. So the equipment flow factors is how much oxygen flow rate you have kept. What is the mask volume or the capacity of the device? How good is the fit of the mask to the patient? And what are the areas of holes in the mask? Suppose if your oxygen flow rate itself is very less, suppose if the oxygen got disconnected, then obviously your FiO2 will be very, very less. And how much is the mask volume? Suppose there is no reservoir for the patient, that is, there is no capacity device, then obviously there is no reservoir of oxygen to supply to the patient during inspiration. So the FiO2 will be less when compared to the devices which has a mask volume. And quality of the fit, how good is the fit? Suppose if the fit is not proper, obviously room air will get entrained and the dilution of oxygen with the air will happen and it will lead to lesser FiO2 inhalation. So these are the equipment factors. See, what are the patient factors? Whenever the respiratory rate is high, the patient is going to entrain more amount of air from the outside and your FiO2 will get decreased. Whenever your tidal volume is more, again, the patient is going to entrain more amount of air and your FiO2 will get decreased. The same goes for peak inspiratory flow rate. And the additional factors like vapor or humidifier, because if you are going to use a oxygen supply without a proper humidification for a prolonged time, it will lead to non-compliance of the patient. So this again is a variable performance device. So variable performance device, what happens is whenever the oxygen flows and fills the volume of I will take the simple face mask as the variable performance device first. So whenever the oxygen flows and fills the face mask and the volume of face mask, again, whenever it is continuously filling, say you have kept 6 liters of oxygen, the oxygen will continue to fill the face mask and also continue to escape through the vents. So whatever the patient is inhaling is mostly the oxygen rich air during inhalation. Suppose if your tidal volume